Good morning or good afternoon, everyone. And thank you for taking time out of your day to participate in this webinar. It's great to have so many people joining us and interested in this topic. I would like to start by acknowledging the traditional territory of the Coast Salish people in southwestern British Columbia, where I am very privileged to live and work. I would also like to acknowledge the traditional territory of the Lheidli T'enneh, which I am fortunate to have returned to today in order to give this webinar at UNBC. I also want to acknowledge and thank Professor Margaret Greenwood, my postdoctoral supervisor and the academic lead of the National Collaborating Centre for Aboriginal Health, and all of the staff at this centre for their support during my postdoctoral work. In her 2009 book on Indigenous research methodologies, Margaret Kovach states, "We know what we know from where we stand. We need to be honest about that." 20 years ago, when I was first invited by the Lillooet Nation in southwestern BC to start providing occupational therapy for their children and youth, I had no clue where I stood as an occupational therapist of Welsh and English ancestry in relation to members of the Lillooet Nation, or more broadly, Indigenous peoples in Canada. Over the years, through my relationships and experiences in community, I have learned how who I am is inextricably tied to and shaped by the broader relations of power in our settler colonial society, and how my position of privilege can show up and play out in my relationships, interactions, and experiences as an occupational therapist and now as a research partner. Today's webinar, then, is a continuation of my thinking about and my concerns for the idea and provision of rehabilitation services and programs. And by that, I'm including occupational therapy, speech and language therapy, and physiotherapy with Indigenous communities, families, and children that started many years ago when I was working with the Lillooet Nation. My hope is that this webinar contributes to a greater dialogue in Canada on thinking more critically about the concept of children's rehabilitation with Indigenous families and children in Canada, and how these rehab programs and practices can be responsive to the historical and ongoing effects of colonization. I'm also going to spend some time highlighting some current approaches and practices that are aligned with the underlying principles of cultural safety. As I go through the webinar, please post your questions in the chat box and we will get to them later on. So to start off, we're going to have a first of two brief brainstorming sessions using the chat box. And what I'd like to ask you to do, without thinking about it too much, is when you think about the word disability, what immediately comes to mind? If you could enter some words without thinking too much into the chat box, and we'll see what comes up, and I'll share some of those. What we'll be doing with the words is, after the webinar, when it's archived, we will turn the words into a Wordle graphic. So some of the words coming up: special needs, limitations, delays, lack of ability, not normal, challenges, stigma, diversity, accessibility, social construct, invisible for most, loneliness, embracing differences, difficult, equipment, mental and physical, isolation, strength. So lots of different perspectives on what that concept holds. And what we're going to be doing in the next section is exploring some of those ideas. Before we do that, I would like to highlight two key points in thinking about this concept in relation to Indigenous families and communities. An essential first step, I think, in thinking about this Euro-Western concept of disability and rehab in relation to Indigenous families is to appreciate that there is no one perspective or understanding that will be universally applicable. As many of you know, Indigenous families that include First Nations, Métis, and Inuit families in Canada are raising their children in vastly different geographical, socioeconomic, and cultural contexts. Also, although many families live in urban centres, there can be a great deal of mobility both within and between cities, and back and forth between urban centres and rural nations or communities. Also, the demography of Indigenous families differs significantly from non-Indigenous families in Canada, with a fast-growing and youthful population and with larger families and younger parents. Another key point to consider is that currently there is a worrying absence of useful and reliable population-level data on childhood disabilities and health conditions experienced by Indigenous children in this country. The three most common neurodevelopmental disorders amongst all children in Canada are autism spectrum disorder, cerebral palsy, and fecal alcohol syndrome disorders. However, there are no known statistics on the number of Indigenous children in Canada with autism or cerebral palsy, and virtually no relevant research on these disorders within this population. This lack of reliable data is a serious injustice because it impairs the provision of timely, adequately funded, and effective programs and services for Indigenous children. In my work, I seek to bring a health equity lens to children's early years, drawing attention to how policies and practices can support families and children's equitable access to health and healthcare. A key federal policy that is galvanizing provinces and territories across Canada to take action towards ensuring that Indigenous children, regardless of where they live, have access to social and healthcare services that are equitable to the wider child population is Jordan's Principle. As many of you know, Jordan's Principle is a child-first principle created to honor Jordan River Anderson, a little boy from Norway House Cree Nation in Manitoba. Jordan was born in 1999 with a rare muscular disorder and lived for over 2 years in a hospital while federal and provincial governments argued over who would pay for his at-home care. Sadly, Jordan passed away at the age of 5 in hospital. He never had the opportunity to live at home, and what happened to Jordan would not have happened to a non-Indigenous child in similar circumstances. In 2006, the Government of Canada committed up to $382.5 million over 3 years for a Child First initiative, and there are currently multiple initiatives underway across the country that aim to provide Indigenous children with increased access to health and social services and support. And I would encourage you to become familiar with the Jordan's Principle initiative in your province or territory, because this funding will likely result in, if it hasn't already, an increase in referrals to and use of children's rehab services. Increasing Indigenous children's physical access to rehab services equitable to the wider child population in Canada is key. However, these programs and services and the various organizations that host and administer them also need to be experienced as culturally safe by Indigenous communities, families, and children. As I discussed, this involves a radical shift or change in how rehabilitation is thought about and delivered. So how we think about disability influences how rehab services are designed and delivered, and their potential relevancy and cultural safety for Indigenous communities, families, and children. Recent critiques from within the field of rehab in Canada and internationally have expressed concerns about the tendency of a biomedical model to frame disability as an individual problem and disregard how social, economic, historical, and political factors shape families and children's experiences of disability. Despite these concerns, a biomedical model, which is well aligned with neoliberal policies, continues to have a powerful influence on how disability is understood within the broader population. And it also continues to shape how we educate occupational therapists, speech language pathologists, and physiotherapists, and also how we structure the delivery of rehabilitation. In many parts of Canada, accessing specific health-related funding and or specific services or resources is dependent on an individualized and biomedical process of standardized assessments in the assigning of diagnostic labels or conditions to individual children. Underlying this process is the interpretation of developmental differences as deficiencies. And I think we saw that in some of the brainstorming words that came up just now. This view of disability is often clearly evident in reports written by rehabilitation therapists. Critical scholarship has raised concerns that for Indigenous children, the assigning of specific disorders, delays, or disabilities can represent another deficit-oriented label for a population who have experienced being historically categorized and stigmatized as, I quote, the inferior other. There are also concerns about the use of standardized assessments and decontextualized assessment processes with Indigenous families and children. There is also some evidence that the timing of milestone achievement may differ for Indigenous children. For example, using population-based data, Finley and colleagues in 2014 looked at developmental milestones for Inuit, Métis, and off-reserve First Nations children in Canada, based on developmental domains collected from the 2006 Aboriginal Children's Survey. Results indicate that gross motor and self-help skills were achieved earlier, whereas language skills were achieved slightly later than in Canadian children in general. Rather than focusing on treating a disability, a social model of rehab focuses on promoting social inclusion, equal rights, and addressing underlying socioeconomic and political structural inequities. So in an attempt to merge these two models, the individual and the social model, and create an accepted international conceptual framework, the World Health Organization launched the International Classification of Functioning Disability in Health, otherwise known as the ICF, in 2001. However, the capacity of the ICF framework to shift rehab beyond individualized, deficit-oriented, and decontextualized perspectives continues to be debated in the critical disability literature, as does its relevancy for Indigenous populations. Individual and Western models of disability are in sharp contrast to many Indigenous perspectives that focus on strength, agency, and well-being. In Canada, rather than critiquing or focusing on illness or disability, language and concepts, First Nations, Inuit, and Métis communities and health organizations have advocated for distinct perspectives of health that often share a focus on well-being, balance, harmony, and healing. Well-being often involves a balance in the mental, physical, spiritual, and emotional aspects at the level of the individual family and community or nation. Achieving and maintaining balance and well-being is frequently a relational process achieved through connections to and between the land, the spirit world, and community. So a biomedical and individualistic perspective of disability often focuses up here in the leaves of the tree, on what is visible and measurable. And 20 years ago, this is what I was initially focusing on, until I started to understand how families' everyday lives was shaped by other broader factors that couldn't be accounted for in that way. A social model draws our attention to the trunk of the tree, the influence of social determinants, and their intersection with disability. Both of these models, the individual and the social, have been critiqued for failing to recognize or be responsive to the impacts of the distal root causes of disability, in particular, the disabling impacts of historical and ongoing colonial structural inequities. It seems that every day there's a new study published that shows how children's early relationships, their early experiences and environments impact their health and well-being across the life course, as well as the prevalence and extent of developmental delays, disabilities, and health conditions. In that context, colonization has been described as the broadest and most fundamental determinant of Indigenous health and well-being in countries where settler colonial power continues to dominate. However, prevailing perspectives on disability and mainstream rehab funding and organizational and practice approaches have largely failed to recognize or explore how to change in order to be responsive to the multifaceted disabling impacts of colonization on the health and well-being of Indigenous communities, families, and children. In particular, understanding the residential school system, the 60s scoop, and currently the child welfare system in Canada as forms of colonial structural violence in that they unfairly target the removal of Indigenous children from their families and home communities in ways that do not apply to the wild child population in Canada, is at the core of understanding why Indigenous parents or caregivers can be extremely reluctant to access or fully engage with children's programs and services. Evidence indicates that parents may choose to not engage in child-related programs, including children's rehab, for fear that they will come under greater scrutiny from child welfare authorities and their children will be apprehended. Parents may also avoid these services in order to protect themselves and their children from the trauma of racism and discrimination. Given this context, rehabilitation professionals have an ethical responsibility to critically reflect on their taken for granted ways of thinking and being and doing in their relationships and work with Indigenous communities, families, and children. So cultural safety is a tool to help us with this important work. And before we go on to look at cultural safety, we're going to just pause and do another brainstorming. And this time, what I'd like to ask you to do, again, without thinking about it too much, is what word immediately comes to mind when you think about providing rehabilitation with Indigenous children. And I'll give you a few minutes and read some off as they come in. Complicated, family-centered, listening, community, provide trust and safety, relationship, understanding historical context on complex systems, hope, underprivileged, community-oriented, collaborating, ask communities what they want, elders, the need to build trust, cultural safety, teaching, family-guided, support parents, trauma-informed, power differential, respecting parents and culture, strengths first, take time to build trust, years, big families building trust, integrated with culture, location, client focus. And many of those are going to come up as I go on to the next part where we look at cultural safety. Thank you for sharing those. So as many of you know, cultural safety emerged in the late 1980s from the work of Dr. Ira Hepetsi Ramsden, a Maori nursing scholar, who drew attention to the ongoing and long-term impacts of colonization on the contemporary health of the Maori people. Currently in Canada, cultural safety is being woven through some healthcare institutional mandates and policies and professional practice guidelines for care involving Indigenous people. Some rehabilitation university programs and national and regional associations are also exploring how to respond to the calls to action of the Truth and Reconciliation Commission, or TRC, particularly in relation to recruiting more Indigenous students and providing effective education about Indigenous history and rights, cultural safety, and anti-racism. There is also increasing recognition in the international interdisciplinary rehab literature that cultural safety is an important aspect of effective rehab with Indigenous populations. However, there continues to be a real lack of research in this area. So what is cultural safety? Cultural safety has been defined as an outcome based on respectful engagement that recognizes and strives to address power imbalances inherent in the healthcare system. It results in an environment free of racism and discrimination, where people feel safe when receiving healthcare. Cultural unsafety or risk occurs when a person feels demeaned or diminished or disempowered in the healthcare system and through their healthcare interactions and relationships. In my doctoral research with the Aboriginal Infant Development Program in British Columbia, parents talked about how they felt about these programs in ways that I think highlight what cultural safety looks like or what it feels like for parents, even though it was not framed using these terms by research participants. And I would like to share two quotes from two mothers in this study. As one mother said, "You walk through the door, it doesn't matter who you are or what your circumstances are. There's no judgment. They are really here to make you feel comfortable. I feel like a piece of the furniture, and I make sure in my life, wherever I go, if I don't feel like a piece of furniture, I move on. And it was very easy to feel comfortable here and to relate to others and accept their help." Another mother said, "It's safe for you to express what you need to express and ask for help with what you need help with, because you know they're not going to take it and use it against you or make you feel threatened or anything. They make sure that you feel safe and secure with what you share. So my critical question for organizations and professionals involved in the provision of children's rehab services, and one that is guiding my current postdoc research with Indigenous families and early years stakeholders here in Northern BC, is how can we enhance the organization and provision of children's rehabilitation so that Indigenous families and parents feel welcome, feel comfortable, feel safe and accepted when accessing these services. From a cultural safety perspective, it is the responsibility of rehab funders, managers, and therapy professionals to transform and adapt. And it is only the recipient of these services who can determine whether they are really culturally safe. In this recent National Collaborating Centre for Aboriginal Health publication, I reviewed the current literature on the provision of children's rehabilitation with Indigenous communities, families, and children in Canada. To augment the literature, which was not very extensive, I also interviewed 12 interdisciplinary rehab therapists who had experience of working with Indigenous families and children in urban, rural, northern parts of the country. It's important to note, however, that there's a small number of therapists in each of the rehab professions who self-identify as having Indigenous ancestry. The vast majority of therapists are of varied European descent. In analyzing this literature, I identified recurring and interrelated themes that are implicitly aligned with the principles of cultural safety. These themes provide talking points for further dialogue and research, and generalizations must be taken cautiously, particularly given the lack of research undertaken by Indigenous peoples in this area. I'm going to touch on some of these in the remainder of this webinar, and they are discussed in more detail in the publication. As I learned from my own experiences in community and with community as an occupational therapist, and also supported to some extent by the current literature, importing mainstream or dominant approaches to providing children's rehabilitation into Indigenous communities doesn't work. So if you're thinking about designing and delivering children's rehab with Indigenous families and communities, I'd encourage you to look at the UN Declaration on the Rights of Indigenous Peoples, which affirms Indigenous peoples' fundamental rights to self-determination and self-governance, and to being actively involved in developing and determining health and social programs, which as far as possible need to be administered through Indigenous organizations. This declaration is also consistent with the calls to action of the TRC and with repeated calls from Indigenous communities, organizations, and leaders across Canada for community self-determination of healthcare programs so that they're informed by and responsive to a community's history, current resources, and self-identified concerns, priorities, and aspirations. This community-led and driven approach to rehab service delivery also reflects the key principles of community-based rehabilitation as proposed by the World Health Organization and the UN Convention on the Rights of Persons with Disabilities. But currently, the potential of a human rights perspective to inform and possibly shift and broaden the scope of rehab programs with Indigenous families and children remains inadequately explored. However, I anticipate that transforming and tailoring rehab programs from a human rights perspective will involve dismantling and redistributing power relations as community self-determination becomes central to the provision of these services. In my research, I explore the concept of relationality as a way of moving beyond individualistic and decontextualized perspectives and approaches in early years programming. Aligned with the principles of cultural safety are the interconnections between investing in relationships, which many of you highlighted in your brainstorming, learning from the community about the community, and focusing on strengths and well-being. These are all key aspects of a relational orientation. Respectful, non-judgmental, and empathetic interpersonal relationships and relational processes are the cornerstone of cultural safety and are more important than the content of any intervention tool or program. Rehabilitation models of service delivery that are fast-paced and compress time make it very difficult to build trusting relationships. Rather than focusing on the work to be done, therapists need to be open to slowing down and deferring their professional agendas, making time and space to develop relationships with community stakeholders, elders, and extended family members. However, it's important to recognize that spending time focused on building relationships through which you can come to know a community, organization, or family over time currently lacks legitimacy or value in how rehab programs are evaluated or accredited and how therapists are expected to use and account for their time. From a relational perspective, the health and well-being of the community is inseparable from the health and well-being of their children. Focusing on well-being at the level of the community is well aligned with emerging calls within the rehab literature for a radical shift beyond an individualized pull-out model of service delivery to community-level and population health approaches and interventions. So, for example, this may include working with communities to apply for a grant to improve outdoor play opportunities for young children, collaborating on enhancing language stimulation or early literacy skills with local daycares, preschools, kindergarten programs, or creating greater opportunities for physical activities for children and youth within the community as a whole. Relational processes again involve a shift in power, as rather than viewing community members as recipients of services, engaging in a process of community self-determination values the perspectives and experiences of local families, elders, healthcare, early childhood, and social service providers as being a rich source of knowledge that is key to the co-development of effective, culturally safe, and sustainable rehab services. During this webinar, I want to take the opportunity to emphasize the cultural risks of assessment. Understanding the provision of children's rehabilitation in the context of the inequitable power relations that persist in our settled colonial society is central to understanding how the taken-for-granted practice of using normative developmental assessments can be problematic. I would actually go as far as to describe the use of assessments as a minefield of cultural risk. The very concept of testing and ranking a child's development may be offensive to parents who value and accept their children's differences and prefer to focus on their abilities and wait until they are older before making attributions about them. Also, as I have found in my research, some Indigenous parents perceive developmental screening and assessments as, quote, a test, pass or fail, and express their concerns that a child's inability to reach certain developmental milestones is implicitly tied to judgments about their parenting and used to justify heightened surveillance and intervention by child welfare authorities. Focusing on parents and children's strengths and capabilities is therefore a key factor in making sure that assessments are undertaken in ways that are culturally safe. I would also advocate for deferring extensive paperwork and assessments until a relationship is well established. And I would go as far as to question why a formal assessment is actually necessary. In this 2001 map from Statistics Canada, anything shaded pink to red represents urban Canada. That is census metropolitan areas of at least 100,000 people. The green shades capture varying degrees of rurality. As this map shows, the rural and northern regions of Canada are vast, and addressing the particular strengths and priorities of rural and northern First Nation Inuit communities also warrants a greater national dialogue on and investment in allied Indigenous health or therapy assistance in Canada. There is extensive research underway on this approach in Australia, but currently in Canada, I really don't think we're giving this enough attention. There has been some recent research undertaken in collaboration with several First Nations in Manitoba, which recommends that investment in capacity building needs to be made immediately. These investments should support both short-term capacity building, such as additional training on speech and language basics for caseworkers already working in communities, and long-term capacity building, such as recruiting and funding more Indigenous people into the rehab profession. Currently in Canada, tele-rehab is really being underutilized with all populations. However, the provision of tele-rehab with Indigenous communities is grounded in the principles, again, of community self-determination and partnership previously discussed. Rather than a separate form of intervention, spending time in community and having relationships in place is a key factor in the success of using the available technology as a complement to existing services. Once relationships are in place, tele-rehabilitation can add value in between visits, particularly when it's provided through portable technology, such as an iPad or tablet that allows therapists to provide consultation and training in diverse community settings and engages with involved community stakeholders. So in closing, the available evidence in the Canadian rehab literature points to a radical shift in service delivery that is tailored with and for each distinct community and family context. However, in order for this transformation to be meaningful and long-lasting, it needs to be informed by the perspectives, experiences, values, and concerns of Indigenous stakeholders, including parents, elders, children, and youth. Before we go on to discuss some of your questions in the chat box, I would like to leave you all with the following questions to guide hopefully your own next steps. How do you come to know and respond to the unique and multifaceted context of each family's and child's life, including how their health and well-being are influenced by broader social and structural factors, which are very often beyond a family's immediate control and environment? And how do you take these factors into consideration into your organization's policies and your routine practices? Also, what changes do you need to make at an organizational, professional, personal level in order to provide socially responsive and culturally safe rehabilitation in partnership with Indigenous communities and organizations? And finally, and perhaps most importantly, how will you know if your service is culturally safe? So that concludes my talking part of the webinar, and hopefully we can get to some questions.